You know, in the world of neonatal care, there are some challenges that are just incredibly sudden and severe, and we're about to talk about one of them. It's a condition that strikes the absolute most vulnerable patients, turning what should be a fragile beginning into a desperate fight for survival. We're talking about a devastating condition called necrotizing enterocolitis.
And just so you know, all the information in the slides we're going to be walking through today come from a really comprehensive clinical guide on this topic from DA Arcade Premium Revisions.
So what exactly is necrotizing enterocolitis, or NEC for short? Well, think of it as a devastating gut attack. It's this acute inflammatory disease that goes after the intestines of preterm infants, causing the tissue to literally die off. And in the worst-case scenarios, the intestinal wall can actually rupture, which is, as you can imagine, a massive, life-threatening emergency.
And the stakes here, they could not be higher. For these tiny, very low birth weight infants who get NEC, the mortality rate is a staggering 20 to 30%. Let that sink in. For every 10 of these tiny patients who are diagnosed, 2 or even 3 might not survive. It's a statistic that just screams how urgent it is that we understand this disease.
So, that leads to a really critical question. Who is this enemy actually targeting? Who are the most vulnerable patients in this fight?
This slide really breaks it down for us. You can see NEC overwhelmingly hits preterm infants, especially babies born before 32 weeks and weighing less than 1,500 grams, that's under 3.5 pounds. But here's what's so important to get. It's not only a disease of prematurity. Term infants who have other major stressors going on, like congenital heart disease, they're also right in the crosshairs.
So why does this happen? Well, NEC isn't caused by just one single thing. It's much more like a perfect storm, where a bunch of dangerous conditions all come together at the wrong time to create this catastrophic event right in the gut.
Okay, let's break down the ingredients of this storm. First off, you've got prematurity itself, which means a seriously underdeveloped gut and a weak immune system. Then, introducing feeding, especially with formula, can act as a trigger. Third, something called gut ischemia, which is just reduced blood flow, weakens the intestinal wall. And finally, an invasion of the wrong kind of bacteria can light the fuse on the whole destructive process. It's basically a multifactorial conspiracy against a very fragile system.
And this shows you the chain reaction perfectly. It all starts with some kind of initial injury to the gut lining. Bacteria then swarm this weakened barrier, which triggers a massive inflammatory response that causes the tissue to die. As those bacteria multiply, they produce gas that gets trapped right inside the bowel wall, and remember that detail, we're going to come back to it. Finally, in the most severe stage, the wall just gives way completely, and you have a perforation.
With a disease this fast and this destructive, you can imagine that early detection is everything. This is where clinicians basically become detectives, hunting for any subtle clue that something is going terribly wrong.
And this slide really highlights the challenge of diagnosing it early. The initial signs are so frustratingly vague. I mean, things like feeding problems or a swollen belly could be anything. But as the disease gets worse, the signs become much more alarming. Bloody stools, a tender abdomen, and eventually shock. The entire goal is to catch it on the left side of this chart before it ever gets to the right side.
Blood work gives us even more clues. Clinicians will look for signs of infection, like wild swings in white blood cell counts, and a big drop in platelets. Those are the cells that help with clotting. A drop in platelets is called thrombocytopenia. Another huge red flag is something called metabolic acidosis, which basically means the body's chemistry is dangerously out of whack because of all the stress.
But to really crack the case, you have to see what's happening on the inside. An abdominal X-ray is the main tool here. It can show gas where it absolutely shouldn't be, like in the veins of the liver, or free air just floating in the abdomen if there's been a perforation. But there is one sign, one definitive piece of evidence that clinches the diagnosis, the smoking gun, if you will.
Pneumatosis intestinalis. This is the term that every single neonatologist and pediatric surgeon knows and dreads.
So here's the key. Pathognomonic is a medical term for a sign that is so characteristic, so unique, that if you see it, you have your diagnosis, period. And for NEC, that sign is pneumatosis intestinalis, seeing those little gas bubbles trapped within the intestinal wall itself on an X-ray. It is the visual proof of that bacterial invasion we talked about. It is the smoking gun.
All right, so once that diagnosis is confirmed, it becomes a flat-out race against time. The medical team has to launch a counterattack, and the battle plan has two very distinct strategies.
Initially, the strategy is medical.
First thing you do is completely rest the gut. That means no feeds, a tube is placed to decompress the stomach, and the baby is supported with IV fluids and powerful broad-spectrum antibiotics. But if the bowel perforates or the baby's condition just keeps getting worse despite all that support, well, then the battle shifts to the surgical front.
Now, surviving NEC is a massive victory, but the battle often leaves scars. The aftermath can create lifelong challenges, and that's exactly why prevention is just so incredibly important. You see, if a large part of the intestine has to be surgically removed, it can lead to something called short bowel syndrome, which is a really serious condition affecting how the body absorbs nutrients. Other potential problems include strictures, which is a narrowing of the intestine, recurring infections, and even delays in growth and development down the line.
So how do we stop this perfect storm from ever even forming? Honestly, this slide is probably the most important one because it's all about the best defense, being proactive. Prioritizing breast milk, which is uniquely protective for a baby's gut, is absolutely key. Feeds have to be introduced slowly and very cautiously. Some guidelines even suggest using probiotics for these high-risk infants. And above all else, constant, vigilant monitoring is just non-negotiable.
And this leaves us with a pretty profound question to think about. Medical science is getting better and better at saving extremely premature babies, really pushing the boundaries of what's possible. But as we get better at that, we're going to inevitably face their greatest challenges, like NEC, more and more often. So conquering this disease isn't just a clinical goal, it's a fundamental responsibility we have to our smallest, most fragile patients.